Good afternoon, everyone. Actually, we are wrapping up this very exciting and hopefully very informational meeting. It is really not easy to actually follow with all the prior wonderful speakers from a spectrum of specialties. So I just want to wrap up and actually share our experience since the beginning of March through May, which had been a very interesting actual time for us. We remained open as a clinic, and then with fully functional, with some reduced working hours. So the title of this talk is supposed to be special consideration for SARS-CoV-2 infection in patients with lysosomal disorders. But basically, I'm gonna take lysosomal disorders as a start point for any patient with a rare disorder. Because the SARS-CoV-2 epidemic unfortunately disfranchised many patients who had acute illnesses such as heart attacks or cancer screenings, but also the group of patients that may have escaped from the medical attention when all the eyes are onto very interesting aspects, an infection with very interesting aspects, and obviously taking lives, and there's an emergency. We just kind of left our patients as a silent crowd at the back burner. So I just want to bring up what we had done, and with some common sense, take away points, I'm going to wrap up this meeting. So I have nothing disclosed regarding this particular presentation. And then at the end of this 10-15 minute talk, we're just going to go over a little bit about the impact of COVID-19 pandemic on rare disorders. And then we're just going to review general guidelines for management of a patient with a primarily affected with a lysosomal disorders. The other speakers already talked about potential complications of a secondary or chronic phase of the disorder. This is the multi-system involvement, and emphasize some mitigation measures. These are all within the CDC guidelines. So this is the headline from Washington Post. It is not in the first page; it's in the health page, and this was published actually at the beginning of June. And so this is a patient of Lafora disease, and the whole article actually talks about how the researcher and the lab has been closed, and these patients actually they are really afraid that they are not only going to get the care but also the research which very much needed for this group of patients will lag behind, and because of the whole eyes focusing on the COVID-19 research. So this is from actually one of the CRO, VGC, and this summarizes what has happened since the beginning of March and for the enrollment of trials. So basically, since March, there were 62% of the sites that were open. They were decreased from the beginning. But if you look at the beginning of May, this 62% became a mere 11%. So there were only 10% of the sites were operational. What has happened actually for the trials that are really going on? So that is, they look in the reporting of the serious adverse event reactions. So they were almost 1/4 decrease in the reporting of serious adverse events when you compare generally what has happened before. It didn't mean that during this time serious adverse events didn't occur. However, the patients didn't come. So the pandemic hinders access to medical care for patients with rare diseases. So the first bullet is from European Rare Disease Organization. So they had a small survey among patients who suffer from any rare disease. And 90% of these patients who actually responded to the survey, they thought that they were adversely impacted with the SARS-CoV-2 pandemic because of their lack of medical care, delayed treatments, or their reluctance to seek medical attention, or a combination of that. So among this 90%, about one third actually they think that their lives have been threatened. So if we think that their trials for cancer or any similar trials like gene therapy trials, we know they are going on very slowly or get halted during this pandemic. So what happened in our center? So we are in the midst of suburbia, and we serve for what is called the DMV area, District of Columbia, Maryland, and Virginia. This is our local patients come from. However, 50% of our patients actually travel nationally for research studies, and we provide also medical care to those patients. So basically, even though we try to remain open, our patient care is impacted generally as a clinical service and any research related activity, clinical research, about one third. So despite there are efforts to keep the center open, we were not able to fully serve our patient population. So the clinical study visits were the least impacted. We tried to get these patients to their visits, so we didn't have to deviate. For the patients who had to travel, we had to defer because there is lack of travel or the high incidence of infections, such as New York, New Jersey, Connecticut area, or the patients who had to drive. That's because there was lack of rest areas, and it is impossible to drive about 6-7 hours without stopping for a bio break. So for what happened to our infusion and injectable therapy clinic, so this we try to not to skip the visits, but this got minimally impacted, about 20% of the services. So this is partly if the beginning of the year, there's some patients have to switch insurances, and unfortunately, during the SARS-CoV-2 pandemic at the beginning, the things moved very slowly. So that was one thing. The second thing was some partially, that is the shipment of the drugs got impacted. And the third thing is kind of misinformation with the patients. Actually, at the beginning, patients had a general thought, and this is partially driven for some misinformation from their own nurses, saying that they would rather wait and write this out for a month or so during the lockdown period. But obviously, this is here to stay until either there is herd immunity or there is a vaccine that is provide immunity to the major of the population. And obviously, all our patients are regarded as high risk, so they didn't want to venture. So they would rather skip their infusions rather than coming to our center, which we had that is the mitigation measures taken at the very beginning. So we use telemedicine only for well check of our patients. We focus on the pediatric and actually infant, very small children population. And because they are the most vulnerable, not for the COVID infection, but missing their treatments. So we want to get the trend. Luckily, none of our pediatric patients missed their infusions. and or other treatments. And I'm going to talk about at the end how we did that. So the only other reason why we use telemedicine is to provide information about each stage of the COVID-19 pandemic, because the information actually kept on changing, both for treatment guidelines and also the information is about the use of PPE, masks, so on and so forth. So how do we manage patients? Given that we have at least a good year for if there is a vaccine to take place or there's herd immunity, so we're looking into 2 years of this continuing pandemic at different stages. So how do we continue managing these very vulnerable patients? From this point on, what I would like to do is I would like to just answer some of the questions that we had to answer to the sponsors of the trials, uh, because they are trying to understand our risk of actually having a higher incidence of patients of COVID infections. So basically, the first question is, were our patients? We follow more than 200 patients with different lysosomal storage disease. The majority is Fabry and Gaucher patients. So I just did a very rough statistics. We had 2 proven patients with COVID infections, 2 probably suspicious patients, and 1 had some signs. The patient was actually totally self-distancing, but we actually had the patient tested and proved to be negative. So this is a very, very small number, and it's probably not statistically significant. But when I compare with with the counties statewide, actually the number actually corresponds with the number of the COVID-19 infections in the state and in the Fairfax County where we are located. So if roughly we follow about 200 patients, 2 proven is 1%. And the number of the whole population. And the COVID-19 positive cases in Fairfax County since the beginning of the pandemic is about 1.2 and 0.7% roughly statewide. And Virginia is a big state with different actual counties with different socioeconomic backgrounds. So we try to understand there is, in addition to the lysosomal storage disease that the patient suffers, if there is additional immune predisposition to any viral infection. So basically, we were questioning whether there are any problems with T cells, and we know that Gaucher patient suffers from B cell abnormalities. So we did offer immune phenotyping. We did in about 10% patients. So among these 10%, roughly 2.5% may have had increased vulnerability with T cell abnormalities. 1 patient wanted rituximab. So obviously we have some patients post organ or solid organ transplant. They are very, very high risk. So this is in addition to that. And then we assessed routinely. Now it's our routine lab procedure to assess the baseline inflammatory response, and we used the high risk factors for COVID-19 infections, and now actually we do it as a routine clinic. So we do fibrinogen, D-dimer, obviously we do ferritin for Gaucher patients, but we move that to other patients such as Pompe and Fabry. So basically, among all these patients, the most common finding in both Gaucher and Fabry patients were mild increase in D-dimer. So D-dimer is the last step of the thrombosis pathway, and so these patients have increased predisposition to any thrombotic event. So this will give us the idea how we manage these patients. So they need to be on thrombolytic therapy, probably if they were to develop moderate or severe symptoms. So we had one proven case with Fabry, and we one case with proven for Gaucher disease. And the infection rates did not actually correspond with the disease severity. Both of them were male, they were young. One of them was about 23 years of age, and it corresponded rather with the socioeconomic trends in the region. So we have a very high positive Latino population with SARS-CoV-2 infections, and both patients were of Hispanic background, and then their jobs were related to primary contractual jobs that one was a painter and the other one actually did house repairs, so on and so forth. If you look at the CDC guidelines, regardless of their lysosomal disorder, are patients already in the highest risk. So the risk factors in general is multi-organ and respiratory involvement or neuromuscular disease. Actually, this is probably for every single patient we follow. Solid organ transplanted patients, cardiac and renal, that actually involves a portion of Fabry patients, and patients receiving other immunosuppressive treatment will or have received chemotherapy. This is maybe important for some novel therapies coming up that requires immune suppression. So we need to reevaluate the mode of immune suppression and the effects of immune suppression. But I think among all these, the data, and we these are all theoretical, and we don't have current data to support this. But I think that is the highest now is the high risk occupations with less chance of social distancing. So basically, contractors, people working in the correction facility. We had one patient who developed profuse diarrhea, and patient had Fabry disease, but we immediately had him tested. We're still waiting for the results. Nurses or nursing aides that work in the hospitals or the physicians. So these are all really under high risk because of the highest chance of exposures. So the second question is, do primary disease symptoms worsen with the SARS-CoV-2 infection? So fever actually was the most predictive sign, and we take more than 99 degrees Fahrenheit as fever for these patients. The others are that what is reported by the CDC, worsening pain, fatigue, and diarrhea for the Fabry patients. So what we did is we withheld treatment. That is because we couldn't accept these patients, nor if they were home nursing. That is, we couldn't send a nurse to until there were 2 consecutive negative PCR testing. So the question is, I'm going to discuss with the second case, are there any asymptomatic infections? So this is one of the patients. That patient had Gaucher disease. He's a 42-year-old male. He is splenectomized as a diagnostic procedure. We did repeat his immune phenotyping. He had an abnormal prior to the start of therapy. Now his immune phenotyping with the parameters we follow was within the normal limits, and he's been on stable enzyme replacement therapy for the past 10 years. And the only presentation of Gaucher disease, in addition of not having a spleen, is clinically is he has osteopenia. So he reported fever for 2 days on and off. The max was 102 degrees Fahrenheit. I sent him to the emergency room for a full workup, and he was breathing normal in room air. He didn't have any respiratory symptoms. So the only finding that his ferritin increased, it was about 40, then it increased about 400, but his D dimer was negative. He was started on broad spectrum antibiotics, so we're going to actually restart his treatment. And what is actually his antibodies are undetectable. So this is our only experience with this patient, but we have others. We have a physical therapist who had actually a prolonged COVID infection, and her antibodies are negative, and this has been discussed before. that is whether these patients will be more vulnerable to a second infection or not. But what is more important here, I want to show his CT scan. So if you look at it, he has the ground glass appearance in a scattered patchy manner. So basically, he had the full-blown COVID pneumonia without being having any symptoms. So this comes when you have fever or any symptom that is relevant to COVID infection. Probably there is no asymptomatic COVID patients. So basically, this patient needs to have a follow-up evaluation for lung findings, whether this is going to go fibrosis, decreased lung functions, or so. So basically, we emphasize continuation of therapy without interruption, and then actually there is some of the children's parents started self-infusing their children. These patient parents we had either had a medical background or we had them trained before, and then what we started doing is some patients with very long infusion times, 4 or 5 hours for Fabrazyme, if they had no issues before, or some patients with Gaucher disease, we started doing something start and go when we don't have any concerns for safety. So the nurse comes in, starts the infusion, obviously takes the vitals, starts the infusion, sets the pump without any actual ramp up infusion schedule, and then the nurse leaves, and then the physician takes over as the on call for any issues that may happen. So we tried this for 3 or 4 patients, and so far all of them did very well. So we managed the comorbidities. We did a very careful evaluation of concomitant medications. So I'm not going to go over this, but truly the hydroxychloroquine actually has been pulled as an emergency medicine, and actually NIH stopped the trial for the lack of efficacy for the long term in an actual hospitalized patient. But it's still maybe in other countries as an outpatient treatment modality. So I need to remind that there is lysosomal toxicity in a long-term, prolonged treatment. And we know actually we use this as a lysosome inhibitor. So the major concern is obviously the cardiac toxicity. So for especially the azithromycin and hydroxychloroquine in combination. So that may be used for other countries, but obviously any Fabry patient with a cardiomyopathy, we look at their QT intervals, and all of them had borderline QT intervals. So basically, this is a major concern. And similarly, hydroxychloroquine is a drug that cannot be used with substrate inhibition treatments that are available on the market. And also there is the liver toxicity associated with antivirals. So the mitigation of possible is exposure. So basically the patients, the lack of significant vulnerability of these patients, I guess all the patients actually mitigated and they self-distance. But what we did as mitigation in the clinic before even the guidelines, so we instilled a staff surveillance. We actually use PPE not to get COVID infections, but also given that we assume everybody is infected now, we do not, if there is anything that we're not aware, that's obviously the staff to protect the patient. So, and then we remove some of the office procedures like pulmonary function tests that we were doing on the Pompe and other patients. That is because it's high aerosolization. So we recommend guidelines for high-risk social distancing, and we have a very low threshold for testing and family screening. But truly, that is the common sense measure. So basically, in summary, SARS-CoV-2 pandemic poses truly an added risk to a patient with a rare disorder. And the risk is not probably primarily getting the infection, which is a high risk too, but is the hindering of the medical care, therapy interruptions, and the research stopping of the clinical research that was in place before. And comorbidities and concomitant medications actually need to be carefully reviewed, and then we need to have a baseline data of all these patients in case they develop COVID infections, so we can share with the treating facility. So currently, our experience is the socioeconomic factors may be the determinant of susceptibility to SARS-CoV-2 infections. That is as seen in our cohort. And treatment plan can be devised around social distancing guidelines and patients eased without therapy interruptions. So they need to know that this is not going to go away and you cannot withhold your treatment for months. So the therapy guidelines are currently changing, so we're going to have some more guidelines when the vaccines are available. So they should be in line with the primary disorder and the LSD specific therapy. So basically, if the primary treatment for LSD, such as substrate inhibition, interferes with the drug of choice, then probably you need to, for a SARS-CoV-2 infection, probably you need to put the LSD treatment on the side to treat the acute phase and need to decide when you're going to go back. So, and then the most important thing is the very low threshold for testing and the detailed evaluation of at-risk patients with complications. So I would like to thank of all the audience, and we'll be pleased to answer your questions.